Okay, so where we left off was talking about placement of our 4 and 12 lead. Once those leads are in place, then we want to start our monitoring, and we can print a sample rhythm strip. Now again, you won't know what it means, but if you'll know once you've had some experience in doing this what artifact looks like. And if there is any artifact there, then you want to make sure that the cables are plugged in, make sure everything's hooked up the way that it should be. And then check your placement, make sure everything is sticking to the skin, especially if the patient is very diaphoretic or sweaty. You're going to have some trouble with those sticking. So you may want to dry the patient off. You may need to put a new sticker on. So just take a look and make sure everything is where it should be to see that you got a good reading. Talking about past heart surgeries and cardiac assistive devices. So open heart surgeries have been performed for decades. And so there are different types, different reasons that they're doing them. Coronary artery bypass is where they take a chest or leg blood vessel and sew it into the aorta and coronary artery beyond the point of obstruction, basically bypassing that part that has now died off so that the rest of the heart can continue to get blood flow. There's percutaneous transluminal coronary angioplasty, where a tiny balloon is inflated inside of a narrowed coronary artery. And so this may be done because of a blockage or because of collapsing of a vessel due to arteriosclerosis. Patients who have had these open heart procedures may or may not have that long chest scar. That should definitely be something that you're asking about if you notice it and they're complaining of chest pain. We want to treat chest pain in a patient who has had any of these procedures the same as a patient who's never had any heart surgery, meaning that we want to take it serious no matter their history. We want to make sure we're giving them the same treatment. Other patients may have implanted cardiac pacemakers, and so different reasons that a person would get a pacemaker and then different ways that they act. So some pacemakers function all the time and set the regular pace and rhythm for the patient's heart all the time. Some of them only function when they're needed. So if they detect that a patient's heart rate has dropped below a certain point, then they would kick in and start working. You can also have dual pacemaker and defibrillators, which we'll take a look at here in just a second. Looking at pacemakers, these maintain regular cardiac rhythm and rate, and so they deliver electrical impulses through wires directly in contact with the myocardium. So essentially, their heart was not functioning the way that they should. Remember, we talked about automaticity and how the SA node was setting the pace of the heart. Eventually, if that fails to do so for a variety of different reasons, it could be because of loss of tissue function. They might have tachycardia, they might have constant bradycardia, they might have irregularities like atrial fibrillation, something that led them to need this pacemaker to keep that regular rate and rhythm all the time. Generally, this is implanted into the upper left portion of the chest, right under the skin, and you can usually see this, a small bulge under the skin. It's not too large, but a small bulge there under the skin that you can feel and palpate. And the patient usually carries a card to describe and tell you what kind of device is this, where did they have it implanted, what date was it implanted, when have they last had the battery checked. So you might ask them to see that card if you need additional information about it. This is kind of what one looks like. That would be placed right underneath the skin. And again, the small wires feed directly into the heart, and they provide that electrical impulse as needed or all the time, depending on what it is. So this technology is pretty reliable. The batteries last for a long period of time, some for 3 years, 5 years, and now as we're getting more advanced with technology, batteries are starting to last for decades even before they need to be replaced. If the pacemaker does malfunction and it's not working the way that it should, the patient might experience syncope, dizziness, weakness due to an excessively slow heart rate or other irregularities. We want to call for ALS probably and transport these patients as promptly as possible. Looking at automatic implantable cardiac defibrillators, again, a patient could have just a pacemaker, they could have just a defibrillator, or they could have one that is a combination of both a pacemaker and a defibrillator. So make sure you know what you're dealing with here. If it's just a defibrillator, this is usually used by someone who has survived a cardiac arrest due to a previous ventricular fibrillation or other abnormality there. And it constantly monitors the heart rhythm and it shocks as needed. So if it senses that the patient is going into ventricular tachycardia or another deadly arrhythmia like that, it will go ahead and deliver a defibrillation. Usually this happens without warning for the patient, so it can be quite scary for them if they're not sure what's going on. They may have already been feeling bad and feel it fire, but if it happens because of a misfire, it can be really scary for them. The electricity here is generally low, so it shouldn't affect the rescuers, meaning that if it shocks the patient, you're not in danger. You shouldn't feel that. It's much less than what's being delivered from an AED or an external defibrillator. Looking at an external defibrillator vest, this is a vest that has a built-in monitoring system with electrodes and defibrillation pads worn by the patient that's attached to a monitor. Now, this does use high energy shock, so this could be a danger to you, but it does usually give a warning that it's about to deliver a shock, just like an AED would. These vests are usually worn by patients who are awaiting more permanent things like a left ventricular assist device, an LVAD, which we're going to look at here in a second, or patients who are awaiting a heart transplant. So we don't want to touch the patient again if it's preparing to deliver a shock. And if you're beginning CPR on the patient because they're pulseless, you can leave this vest in place. It's not going to interfere with compressions, and you're going to allow it to work as an AED would. Like we said, the left ventricular assist device, or LVAD, is used to enhance the pumping of the left ventricle, and it may be pulsatile or continuous. So you might not even feel a pulse for this patient. Usually, essentially, it's just bypassing everything that's happening inside of the heart. And this person has been probably really sick, and they might be waiting for a heart transplant. And this is kind of like a last resort. Now, the LVAD will allow them to go home, and they need to be continuously monitored for battery power. So this is plugged in most all of the time. And if they have the portable battery packs, they're traveling with several of them because they only last a certain amount of time. And usually the patient's caregiver or spouse or child or whoever is their primary caregiver can give you more information about this. And anyone who has an LVAD, they need to go to the hospital where it was placed. So if it was done like at Duke or if it was done at UNC, those are usually the two primary places that do them in our area. They need to go back to that hospital. And usually they have a phone number for their coordinator, and that's who you want to call and get in touch with. So if you're transporting the patient and it is in regards to something cardiac related going on with the LVAD, then we want to give them a call and let them know that we're coming in and see if they have any additional instructions for us. If this fails, all right, so the battery dies or something has happened and damaged the LVAD, the only thing that you can do is compressions, and the patient will likely still be awake. So that's going to be probably really traumatic for them and probably really traumatic for you as the provider, but that's what has to happen. So if the LVAD fails, you will have to do compressions on the patient, even though they are still conscious and talking to you. So understand kind of how that works, and you can look up some additional information regarding LVADs if you have other questions. But again, the caregiver will likely have all of the information for you, and that's really what you need to know is call the coordinator, take them back to the hospital where it was placed, and if it fails, we need to do compressions. Now, cardiac arrest, I'm not going to spend a whole lot of time in talking about this slide and the following slides related to cardiac arrest because I did a whole other PowerPoint presentation on that, but certainly we want to know that cardiac arrest is, of course, the absence of the carotid pulse and cessation of cardiac activity. And so we want to start CPR here, and we're going to utilize an AED. So the AED, of course, analyzes the electrical signals from the heart and identifies either ventricular fibrillation or ventricular tachycardia. But remember, we can have ventricular tachycardia with or without a pulse. And so that's why it's so important that we identify the patient as pulseless prior to applying the AED. And you'll see some test questions that ask about that because the AED cannot detect the pulse. It can only detect the rhythm itself. So it's going to tell you whether it's shockable or not shockable. We're going to follow the prompts that are on that, make sure that we have the pads appropriately sized and appropriately placed on the patient. We should kind of understand at this point how to utilize the AED after you went through your CPR training. Remember, you don't need ALS providers here. This is an EMT skill to be able to utilize an AED. We want to make sure we are getting good pad contact. So again, if we need to shave that chest area, if we need to wipe the patient down, if they're very sweaty or if they're wet, we want to remove them from any puddled and standing water. We want to make sure that we remove any nitroglycerin patches or other pain medication patches that may be there on the patient's skin if they already had that, as that could cause burning to their skin. Not every patient that's in cardiac arrest will require a shock. Remember that if they are in asystole or any other rhythm other than ventricular fibrillation or ventricular tachycardia, it's not going to recognize it as shockable. So we would just continue compressions and manage the patient's airway and look for those other definitive reversible causes that we can intervene on. Few cardiac arrest patients survive outside the hospital without a rapid sequence of events. So early defibrillation is very key here. Having access to an AED, getting hands on that chest and doing those continuous compressions is very important, making sure that we're doing good CPR. This is prolonging the period during which defibrillation can be effective. And so that's why doing compressions all the way up to delivering the shock, even through the charging phase, is very important. Remember, we don't want to do compressions during the analysis phase, but it is safe to do it during the charging phase as long as this is a semi-automatic AED, meaning you have to actually push the button to deliver the shock. If ALS is here and we are working on post-arrest care, we're going to continue ventilations for the patient. Let's say we've got ROSC at this point. The patient has regained a pulse, but they're not breathing on their own. We want to continue ventilations, keep a good oxygen saturation. Ultimately, we're trying to keep the blood pressure above 90 systolic. We want to look at glucose levels here as well, depending on your protocol, and transport the patient to an appropriate facility, although we do want to stay on scene for 10 minutes to package the patient, get that first set of vital signs, get a 12 lead, and make sure that we are ready to transport to an appropriate facility. Looking at some AED maintenance, we want to read the operator's manual. We want to check this daily at the beginning of our shift to make sure that it's in good functioning order. And depending on your department's protocol would be how often are you actually doing maintenance and that type of thing. But we should at least check it and make sure the battery is good every day to make sure that we can use it if we had to. So other things that we are thinking about in relation to the cardiac arrest, and we mentioned some of these, making sure that the electricity injures no one, so everyone is clear prior to defibrillation. The patient's not in any standing water because water can transfer that electricity. Same thing with metal. Those are good conductors of electricity, meaning that it could injure you or someone else. We're going to remove any medication patches, specifically nitroglycerin patches the patient may have been wearing, and dry them off if they're sweaty before delivering that shock. We may need to shave that hairy chest to increase conductivity of our electrical shock. We can consider spinal immobilization for trauma patients here by having someone hold manual C-spine, but we never want to let that interfere with compressions because this is really life over limb and there's no good way to completely immobilize the spine. So we can hold C-spine and we can use a jaw thrust maneuver instead of a head tilt chin lift to do the best that we can, but in this emergency situation, life over limb, we're not super concerned about keeping a total neutral inline spine because there's not much we can do. We've got to do those compressions, which is ultimately going to affect the spinal column. We're going to want some ALS assistance here, and in my previous video, like I said, where I talked about utilizing additional resources for cardiac arrest, that's going to be system dependent. If you have fire department there to do CPR, if you've got ALS, additional ambulances, and supervisors, because we definitely want that family to get some management as well. So we're going to follow our local protocol, but we are going to immediately resume compressions after an AED has delivered a shock. And then we're going to continue on to the next 2-minute point where we would then potentially reassess the patient's pulse in a small window of time as we're preparing to change our compressors, but we want to have limited interruption or limited pause in compression. So making sure that we are checking that pulse, but very briefly to determine if we need to continue or not. If ALS is responding, then we are going to follow their lead as far as their treatment and protocols. All of this right here is talking about transporting during the arrest, but that is not a good standard to follow. We should not be transporting during arrest, both on a state and a national standard. It is recognized that's important to work it where you find it, meaning that we want to go ahead and work that cardiac arrest in the spot that we find the patient, and we want to stay there either until we have regained a pulse, so we've got ROSC, or until we are going to discontinue efforts. There are a few exceptions to that, like with traumatic arrest and some pediatric arrests, so you want to follow up with medical control if you had any questions about that. And then if we get ROSC, again, we want to stay on scene for at least 10 minutes. We're going to get a full set of vital signs. We're going to prepare to package the patient, and then we're going to transport to an appropriate facility. So you can follow up in that cardiac arrest management video if you have any additional questions about that.